Welcome to the deep dive. Today we're tackling something pretty serious, antimicrobial resistance, or AMR. You've probably heard the warnings, this idea of a post-antibiotic future. It's potentially, 10 million deaths a year globally by 2050. It's staggering.
It really is. But what grabbed me about the commentary we're digging into today is how much this isn't just about the bugs evolving. It's also deeply about us, about human
Quote,
factors.
sociological side. That's the twist here.
Exactly, because while the biology, the mutations is obviously critical, these often overlooked social forces seem to play a massive role, especially when you see that resistance rates in low-resource settings are like 3 to 4 times higher.
3 to 4 times higher. Wow.
Yeah, it's a crisis that's really woven into the fabric of society. So our goal today is to kind of unpack that.
Okay, let's do it. We're drawing from the commentary Prescription and Peril, the Sociology of Antibiotics and Antimicrobial Resistance in Low-Resource Settings.
Hmm.
So moving past just the bacteria, what are some of these big social or economic drivers it points to?
Well, a huge one, maybe the foundation, is poverty. It affects everything.
Yeah.
Financial barriers mean people often can't afford a full course of antibiotics, so they stop taking them early.
Which we know is a recipe for resistance.
Absolutely. Or they might buy cheaper, maybe substandard or counterfeit drugs because that's all they can access. Sometimes they delay seeking professional help or skip it entirely just because of the cost.
And what about diagnosis? I imagine that's tied to cost too.
For sure. Lack of affordable diagnostic tools is a massive problem. It leads doctors to what's called empirical prescribing.
Meaning they prescribe broad-spectrum antibiotics just in case, without knowing the specific infection.
Exactly. It's often the only option, but it definitely fuels resistance because you're using powerful drugs unnecessarily.
So you've got poverty driving incomplete treatment and broad prescribing. But what about culture? How do everyday beliefs and habits play into this?
Oh, hugely. The commentary highlights things like the very common practice of self-medicating. People might think antibiotics work for colds or flu, which are viral,
Right, using them when they won't help at all.
or saving leftover antibiotics for later, just in case. And sharing them within families or communities is widespread. It seems helpful, but it's really risky.
Are there other specific cultural things, like preferences?
Yeah, sometimes there are preferences for, say, injections over pills, thinking they're stronger. Or maybe a mistrust of generic drugs, even if they're effective and cheaper.
And traditional medicine, how does that fit in?
It can interact in complex ways. People might use traditional remedies first, delaying antibiotic treatment, or maybe use both concurrently in ways that aren't ideal. These aren't small things, they're widespread cultural norms.
It sounds like these issues thrive where the formal health system is weak.
Definitely. When people can't easily access or trust formal health care, they turn elsewhere. To informal providers like traditional healers or maybe just local drug sellers.
Who might not have the right knowledge about antibiotics?
Often, yeah. Their knowledge can be limited, and they might dispense antibiotics inappropriately. Then you layer on things like, well, corruption in some places, lack of accountability, unregulated markets.
Flooded with fake drugs, potentially.
It all undermines any effort towards responsible use. It's a systemic weakness.
The commentary also mentions the One Health idea. How's that relevant sociologically here?
It's super relevant. One Health connects human, animal, and environmental health. In many low-resource settings, people live in very close contact with livestock. Farming practices, waste disposal, these social realities create pathways for resistant microbes to spread between humans, animals, and the environment. It shows how interconnected everything is.
So with all these deep-seated social, cultural, economic factors, what's the way forward? The paper pushes for community-based solutions. Why that focus?
Because top-down approaches just don't tend to stick.
Yeah.
They don't account for the local reality. Community-based interventions work with the local knowledge, the specific needs, the available resources. That's how you get real, lasting behavior change and a sense of ownership.
Makes sense. Can you give us some examples of what that looks like?
Sure, things like public education campaigns, but really tailored using local languages, local media, getting community leaders involved.
Not just generic pamphlets.
No, exactly. Or strengthening the front line, investing in community health workers, maybe setting up model pharmacies within communities that promote good practices.
And getting the community involved in stewardship.
Yes, absolutely. Engaging local leaders, maybe even traditional healers, as champions for responsible antibiotic use. Forming local committees to track usage, discuss problems. It's also about better surveillance at the community level and even community-based research to really understand what's driving resistance locally and find culturally appropriate solutions.
So wrapping this up, it's clear that fighting AMR isn't just about finding new drugs. It's fundamentally about understanding and changing human behavior within specific social contexts.
Precisely. We need both the biological and the sociological strategies working together. It's the only way.
Which leaves us with a thought for you, the listener. How can understanding the social and cultural context of any community, maybe even your own, lead to better, more sustainable health outcomes?
It really drives home that medicine is never just about the pills or the science. It's always fundamentally about people.